Good evening, everyone. Welcome to A Night In with Newlife, our webinar series designed to get you through the COVID-19 lockdown with as much fertility knowledge as possible. My name's Chris Russell. I'm a fertility specialist with Newlife IVF, and tonight I've got two other fertility specialists with me, Dr. Nicole Hope, our medical director, and Dr. Hugo Fernandes, one of our other fertility specialists who you've met over the previous few weeks. We do like to give you a very brief update on the COVID-19 situation at the beginning of each night. And again, we don't have anything particularly new compared to last week, other than that the IVF treatments have restarted. We've got patients coming through having their stimulation cycles. We have egg collections and embryo transfers ready to take place next week. So it's only good news, and we expect capacity to get even better over the coming weeks. Tonight's webinar, like I mentioned, is entitled The Real Modern Family, and we're going to be talking about fertility treatment options for women in same-sex relationships, men in same-sex relationships, and also single women. So I'm going to introduce now Dr. Hugo Fernandes. He is one of our outstanding fertility specialists. He practices all over the state, but he's mostly based in Richmond. And as well as being a wonderful fertility specialist, he's an excellent artist. And all of the pictures you'll see tonight, particularly the hand-drawn ones, Hugo is responsible for. So without further ado, I'll hand over to Hugo and we'll get started.
Thank you for that introduction, Chris. Yes, some of the pictures on there have been drawn. They're not been drawn by me. They look like a child drawn them. Great topic. I've really enjoyed presenting on this topic as it touches close to home. So I've called this the real modern family, and it's fertility in single women and same-sex couples. I'm going to do the first half, and Nicole come in and do the sort of nitty-gritty towards the end. So what is a family? It's not really a question that we ask ourselves ever, because we're just sort of surrounded by family most of the time. This is sort of the traditional family that is often depicted on TV, or was depicted on TV. It's a little bit Leave It to Beaver. We've got a nice sort of white Anglo-Saxon couple there, 2.5 kids. Not sure which one of those is the half, but 2.5 kids and a dog. And that's sort of the more traditional family. However, TV has shown that the Leave It to Beaver family is not really what's found now. And in fact, Modern Family, when it first came out, was groundbreaking for the fact that it truly depicted what was seen in real life. In particular, the fact that there were two men parenting a child was considered groundbreaking, because when it's been done before on TV, it's been two women. But from this very, very funny series, we know that families can occur in many sort of different mixes. And this particular talk is based on sort of single women, same-sex couple who are adopting, a male couple, or same-sex couple having a child of their own. So what is a family? If we look at the Australian Bureau of Statistics, they would say that a family is two or more people who are at least 15 years of age, can be related by blood, by marriage, either adopted or some other form, and reside in the same household. But we know that that's not true, because people don't have to live together to be in a relationship or to consider themselves a family. We also have the dictionary.com definition, and that essentially says that it's any two people, parents and their children, that are considered a group and may or may not be living together. Again, not entirely true, because you don't have to have kids to be a family. So I quite like the Urban Dictionary definition, which is a family is a bunch of people who hate each other but come together to have dinner each evening. And that probably does reflect what is truly going on. I think what I'm trying to say is that family is whatever you want it to be. Certainly, gay and lesbian people and single people have had to contend with this over the sort of the last few decades, either through being ostracised by their families or not quite fitting in. Gays and lesbians in particular have had to create their family. And this is anything from sisters to co-parents to a chosen family, mama and papa, or a foster family. A family is whatever you want it to be. So if we move on to a little bit of nitty-gritty, a little bit of fertility. For those of you that have been following our webinars over the last 4 or 5 weeks, you'll have picked up some of these numbers along the way, and you'll be very familiar with this chart, which I really like. So the chances of getting pregnant in any 1 month, as we've shown before, is about 20 to 25%. And that number is about as good as a human gets. And that is seen under the age of 30. From the age of 30, if we're looking at that chart on sort of the purple line, from the age of 30, fertility falls. And that's mainly a reflection of egg quality. So a woman's born with all the eggs she's ever going to have. And over time, those eggs disappear as she ovulates. But also over time, those eggs become older and older. So the eggs that you get at 38 are not anywhere near as good a quality as they are at 25 or 30. And that reflects, 38 years worth of smoking, drinking, Kentucky tours, and partying. With IVF, which is that orange line, we can see that your fertility is doubled, pretty much doubled essentially the whole way. But we can't get over the quality issue, which is why the IVF line falls as well. The blue line I like. It's an interesting line. It demonstrates donor eggs, and donor eggs normally come from 30 or so year old women, and their success rate's about 50 to 60% when they have a transfer. And we can see that even at the age of 48 or 50, if we use those same eggs in those women, they have the same success rate. This chart therefore demonstrates that age is the most important factor for fertility when we're trying to sort of counsel you. However, women who are GLBT or single women are not necessarily medically infertile. They're rather socially infertile. It's not that they can't have a child, it's that they don't have everything that's required to have a child. We don't actually know what the fertility or infertility rates are for this sort of group of people, mainly because they've not really had access to IVF or to fertility treatments because of discrimination, or it's not been funded, or they've had to go about it in other ways. But if you think about it, there's really nothing wrong with this group of women. So the chances of getting pregnant should equal that of the general population. And if anything, you'd think that they have less chance of being infertile because same-sex attracted women in particular have lower rates of STD compared to, say, the general population, and therefore less likely to have blocked tubes, which is one of the causes of fertility issues. So we don't really know the numbers, but social infertility rather than medical infertility. So let's do a little bit of basics here. What is it that we need in order to have a child? Well, we need an egg, we need some sperm, we need a womb, and we need a home. And a home is more than a house. It's a house or a building, but it's a family around you as well. Here are the pictures that Chris said are true. The difficulty with all these things is not getting them, it's getting them all together and getting them all to sort of cooperate. That's actually the tricky bit. So if we look at each individually, in a, say, single women or a lesbian couple, we need an egg. So the egg can come from the one patient, it can come from one woman, it can come from the partner. It can come from, be donated, it can come from a friend, family, or can be completely anonymous. As long as it's altruistic, which means there's no money exchanged to purchase this tissue, it can come from multiple places. For a guy, it's a little bit harder because their partner, in a gay couple, their partner's going to be able to supply an egg, but they can get an egg altruistically donated from friends, from family, or anonymously. There's also the ability to go overseas and either get this altruistically or to purchase it, although that is considered frowned upon by Australian law and is actually illegal. In relation to sperm, again, a single woman or same-sex a female couple won't have access to sperm. This can be donated. It can come anonymously from sperm banks or from overseas, or again, it can be a friend, it can be a sibling, it can be a relative. So some women, one woman will use her eggs and she may use her partner's brother to donate the sperm so that there's a genetic link. For a guy, that's a little bit easier in terms of accessing sperm. But again, even if the guy has a medical issue, he too can access sperm via the various banks. In a woman, the womb is usually theirs or their partner's, but surrogacy sometimes needs to be accessed. And in a guy or a male couple, they nearly always have to access surrogacy in order to have a child. Well, a home is what you create of it, and as I said, a home is so much more than just a house. So if we just look at donor sperm come in sort of two main ways. We have a known donor and we have clinic recruited donor. They go through a very similar process, except that accessing them is slightly different. So in a known donor, that typically is a friend or a family member. It can be brother-in-law, can be a father-in-law, if you want a genetic link. But it's someone who's agreed to donate their sperm to you. Whilst it seems straightforward, they have to go through the same process as a clinic recruited. And that essentially means that unless you're a male and a female in a relationship and you're going through IVF together, the sperm must always be quarantined, it must always be tested. So it's never fresh sperm that you're using, it's always a frozen sample. It's important also, obviously, that they're not genetically related. So in a same-sex couple, it could be one female and her partner's brother or father, but it can never be genetically related. In both clinic and known donor, they go through a very similar process. The patient is always, the patient being the male in this point, is always seen by the doctor. We take a really thorough medical history, surgical history, genetic history. We do a sort of pedigree to look at their parents and then also their grandparents quite often. And they undergo testing for infections, medical issues, and we often do quite vigorous genetic testing as well to rule out the really common genetic issues. It's really only after that that we start to freeze sperm. So usually the first sample given is tested for quality, but at the same time we freeze that sample. And whilst it's only one sample that's being presented, we break that down into multiple, what we call straws, so that one sample can actually be used on multiple occasions. And then they're frozen. A guy can give multiple samples if he wants, so that you can build up sort of a bank of sperm, either for your own use or for the clinic to use. And then we, at about 3 or so months, we retest that chap for all those infections. If those infections are clear, then we know that that's a clean batch of sperm and we know that it's safe to use. So the reason we freeze and don't allow you to use it straight off is for protection. It's to protect you from infection. Even though the two processes are slightly different, they occur for the same reason. So people donate sperm because they've been through it before. Maybe their wife or their partner, female partner, had issues, but their sperm was good and they don't want any other people to go through this, so they donate. Sometimes they donate because they've had a family member have to go through IVF and they want to donate to help someone else out. Sometimes it's because it's a way, particularly in gay men, that they see as being a father, or the only way that they're ever going to be a sort of a father. And they may not know who the child is, but they feel good in themselves knowing that they're a parent. And the fourth reason is just possibly because some people are driven to pass on their genetics. Whatever way, or for whatever reason, it's given altruistically, in that a chap can't be paid for their sperm. They need to donate it of their own good. And it is a great thing that they're doing. to donate this to a couple or to other people. What doesn't change between these two groups is who comes forward. We've just finished a big recruitment drive for sperm donors, and we did it in various ways, but it represents all areas of society. So we have young people through to slightly sort of older people. We have people of all cultures, all denominations, and sort of all ethnicities. And we also have people who are sort of builders and sort of more manual through to university and business type people. So it does take all types to create families. The other thing that's equal between these two is the rules and legality around it. So really, the rules or the law states very strongly that this term donor, it's a protected term, and because of it, it states that there is no legal connection between the sperm donor and the child. This means that the male who donates the sperm has no custody rights over the child, but in the same way, the couple or the female who's using that sperm has no rights to child support from that donor. This is quite more straightforward if it's clinic recruited, because there's a sort of an anonymity between the two. It does get blurred when it's a known donor. And so that's one of the important things to remember when you're bringing your own donor, is what exactly is the role of this donor, and does the donor know that that's their role? The other thing that's not entirely true is this anonymity. Anonymous is a relative term, even for the clinic recruited donors. And that's because with the law change a couple of years ago in Victoria, there really isn't an anonymity. The chap always has to know that this child has a right to work out or to find out who their father is, and at a mature age can ask for that information. So you're never really anonymous. So what are some of the options available to single women and lesbian couples? So we have home insemination. We have intrauterine insemination. We have, in a single woman, we have IVF using her eggs but donor sperm. In a same-sex couple, we have egg sharing, so one woman's eggs going into her partner's body or womb using donor sperm. And then there's other options of adopting, fostering, or becoming a parent to their partner's children. Home insemination. Home insemination is essentially the turkey-based method that is often been spoken about, and many jokes made about in Hollywood films. Look, the pros of this are that it's considered, natural, I suppose. It's cheap and it's effective. And the reason it's effective is because you're just really mimicking what's happening in the body. During intercourse, you ejaculate in the vagina very near the cervix, and we know that within sort of 15 minutes the sperm has gone through the cervix and finds itself into the uterus. So if you can mimic that just using, I don't know how many people actually use a turkey-based, I think that's a bit of an American thing, but if you're able to get a syringe and draw up in a sterile way an amount of sperm into the syringe, and push it as high up in the vagina near the cervix as possible, then you're really just doing what nature does. And as a result of this, the success rates are reasonably good. And in fact, they should really mimic the natural success rates, because it's essentially the same process. The downside of this is accessing sperm. So sperm is still difficult to come by. You're obviously not accessing it from a clinic. So there is sort of this black market that exists, and people go online and various websites and chat sites to access sperm. And I know even in some of my own patients who have done this before at home, it's a little bit difficult to sort of be happy with either the quality of the sperm, but the quality of the people that are donating this sperm. Often you're not entirely sure of their history. You don't always have access to their infective screen. If they do give an infective screen, so all the blood tests that they've undertaken, you need to be sure that they're able to stay protected for a couple of months that you're going through this, because the infective screen in 1 month may not apply 2-3 months later. You really don't know the genetics behind this or the family history that the patient has. And as I stated earlier, there's this blurring of the line of what a donor is. The person who's donating, are they really a donor? Maybe they think, maybe you think they're a donor, but maybe they're thinking they're more parenting. So there's pros and cons to both of these. Intrauterine insemination is a bit of a fancier version of this. This is what we do in our rooms. Not in our rooms, in our clinic. The chap comes in, provides a sample, and we spin it down in a centrifuge to concentrate it into a very small volume, get rid of most of the fluid, and then this is what we put back into the womb. It's a very easy process to do, similar to having a pap smear. A little spaghetti catheter goes in, just as that picture shows, and we inject the entire amount into the womb. Upside is you're getting the entire amount of sperm into the womb. Downside is you're getting good ones and bad ones into the womb. The success rate's about 10 to 15%. In order to increase this slightly, we can give you some tablets or some injections to make sure you grow an egg and that you ovulate at the correct time, and then inject the sperm sort of at the correct time of ovulation. That increases your chance slightly, and this is often what same-sex women or single women go through in order to get started. Things are going to get a little bit fancier now, so I'm going to ask Nicole to come in and talk about the sort of more advanced treatment options that we have with getting pregnant. So, Nicole?
Hello. Before I start talking about my section, just to remind everybody that you can submit questions if you'd like to. There's a little question bubble at the bottom of your screen. And so if you could submit some questions now, then we can go through them at the end of my presentation. Great. So I get to talk about the fancy treatments, which ultimately is IVF and surrogacy. So, when is it time to move on from the turkey baster to the test tube? So there are a few different reasons why couples might think about moving on to IVF. Firstly, maybe they've tried insemination a few times and they haven't been successful. And ultimately, IVF is the treatment which does generally give us the highest chances of pregnancy. And so some women may just move on to IVF to maximise their chances. Sometimes there are single women or women in same-sex couples where they already know that they have an underlying medical problem that would probably make it difficult for them to conceive naturally or with insemination. For example, they may know they have blocked tubes or endometriosis, or maybe the woman is older and she knows that she may have poor egg quality because of her age. So that's another reason to go straight to IVF. Sometimes women have a sperm donor who is willing to give sperm, but maybe his sperm is not of a good enough quality or quantity for insemination. For insemination, we need about 3 to 4 million swimming sperm per insemination. But for IVF, we actually only need 1 sperm per egg. So if the sperm is not so good, then maybe we'd be suggesting IVF. Hugo already spoke about doing egg sharing, and we always need to do IVF for egg sharing and also for surrogacy arrangements as well. If people have a genetic condition or a chromosome problem that they want to test for, then that's another reason for doing IVF. We can create embryos and do pre-implantation genetic testing and make sure, hopefully, the embryo we're transferring is a healthy one. So what does an IVF cycle involve? For those of you who don't know, we generally start an IVF cycle with a woman's period. She usually starts off taking an injection at night, which is called follicle stimulating hormone, and this is to make multiple eggs grow. After a few days, she'll start another injection in the morning, and that's called the antagonist injection, and that's to make sure she doesn't ovulate too early. After she's been on the injections for a week, she'll have a blood test, an ultrasound, to see how many follicles there are and how big they are. And then we can work out what's the best time for egg collection. Most women are ready for egg collection between about day 12 and 14 of their cycle. On the day we collect the eggs, that's when we get the sperm and inseminate the eggs. We then grow the embryos for 5 days in the lab, and then we bring the woman back in, and that's when she has the embryo transfer. And then about a week and a half later, that's when we're doing the pregnancy test. So with IVF, when we have the eggs and sperm, we have 2 ways that we can put them together. We have conventional IVF and we have ICSI. So conventional IVF means that we put the egg and sperm next to each other in the Petri dish and we allow fertilisation to happen naturally. To perform conventional IVF, we need about 100,000 swimming sperm per egg. So if we don't have that much sperm, or if the sperm quality is not so good, then we might think about doing ICSI. So ICSI stands for intracytoplasmic sperm injection, and that's where we hunt through the sperm, we look for a sperm that's swimming well, it's a good shape, and then we inject a single sperm into each egg. So we need a much smaller number of sperm to do ICSI. Sometimes when women have their own sperm donor, a known donor, and they may have limited sperm supply, they might choose to do ICSI to try and preserve as much sperm as possible for future treatments. So Hugo's already spoken a little bit about egg sharing, and this is becoming increasingly common amongst lesbian couples. So what it involves is one of the women provides the eggs and the other woman is then has the embryo transfer and carries the pregnancy. So this allows both women to have a biological connection to their child. Sometimes there's actually a practical purpose to it as well. Sometimes there's a couple where one of the women maybe is older and maybe her eggs are not as good quality as what they used to be. The other partner might be younger and her eggs might be good quality, but she may actually not want to carry a pregnancy. So it allows the two of them to come together and have a family that satisfies both of their needs. So with an egg sharing cycle, the main thing we have to do is we have to get the two women's cycles in sync. And so usually the woman who's having the embryo transfer, we will initially put her on the contraceptive pill to make sure that they're both having their period at the same time. And then while one partner's having the injections to get ready for egg collection, the other partner is taking hormones to prepare the uterus for the embryo transfer. Both partners will have to have pre-treatment blood tests and ultrasound and counselling and make sure they're both suitable for egg sharing. You do also have to be prepared that it can be a bit more expensive than a normal IVF cycle because we have two women who are both having treatment at the same time. Now, we've spoken a lot about single women and same-sex women conceiving, but obviously our single men and our gay couples also want to be able to have a family. It is a little bit harder for our men because, as Hugo has mentioned, they need eggs and they also need a uterus. And in Victoria, unfortunately, the same woman cannot provide eggs and a uterus. So our men need to find an egg donor and then they also need to find a separate surrogate. It is possible to do surrogacy in Australia or overseas, and sometimes men may decide if it's all a bit too complicated, they may look at local options like adoption, fostering, or parenting their partner's children. So a little bit about surrogacy. So in Australia, just like egg donation and sperm donation, surrogacy must be altruistic. So we are able to, couples are able to pay for reasonable costs, but you're not allowed to pay a lump sum to someone to be your surrogate. Because of this, people are generally asking friends and family to volunteer to be a surrogate. People do need to be aware that the surrogacy laws are different in every state. There are some states which don't allow surrogacy for same-sex couples. And as I mentioned, in Victoria, you just need to be aware that the egg donor and surrogate must be different people. Because it can be quite tricky to try and find an egg donor and a separate surrogate, there are some people who do decide to pursue surrogacy options overseas. One of the reasons we say that surrogacy in Australia needs to be altruistic is to make sure we're not exploiting people. And so you do need to be aware if you're going overseas, try your best to make sure that people are not being exploited, and also make sure you're aware about the legalities of bringing a child back into Australia. Obviously, you will need to arrange some sort of passport or to bring a child back into the country. And sometimes people do have to factor in that they may be overseas for a few months while they're trying to organise the appropriate paperwork to do that. On the slide, there's a list of a few countries that Australian people do often go to for overseas surrogacy arrangements. Some of those countries have been crossed out, and that's because potentially the surrogacy options are no longer legal in those countries. Often it's quite expensive as well, so these are things to consider. If you are doing surrogacy in Victoria, there are quite a few steps you have to go through, and it is quite a long process. It can take several months before a surrogacy arrangement has been approved and is ready to go. So both the intended parents and the surrogate need to have medical consultations to make sure that there are no underlying medical problems that need to be addressed, and to order the appropriate investigations. Everybody will have to undergo counselling, and there are multiple sessions of counselling. And this is why the process takes a while, is to work through that, because this is obviously a very big thing to ask somebody to carry a baby for you. As well as counselling, there's also quite extensive legal advice, and both the counselling and legal advice need to be given by professionals who have experience with providing surrogacy counselling. So you can't just go to your local lawyer and ask them to provide information. In Victoria, all surrogacy arrangements have to be approved by the patient review panel, and they will want to see that the counselling and legal advice have all been completed. As Hugo was talking about with our donor sperm, we do want at a minimum the sperm that's used to have been quarantined before it's used in a surrogate, and if there are embryos created, then ideally those embryos have been quarantined as well. So sometimes, unfortunately, you can't just go straight from approval from the patient review panel to straight away the next month having an embryo transfer into a surrogate. Another note is that for men who are looking at a surrogacy arrangement, we can't do sperm mixing either. Some men, I think in some countries it is possible, but that both men provide a sperm sample and they inseminate the eggs with sperm, and you don't know who the sperm comes from. But in Victoria, we do need to know who is the biological parent of every embryo, so we're not allowed to do that either. So these things are changing very rapidly. We're getting more and more information and resources, and I've just got up there a list of websites that you can access to read up more about these different scenarios. And I've come to the end of my presentation. So now we have some questions, and I'm going to start with the first question, which is, does Newlife have donor sperm? And the answer is yes. Not quite ready, but yes. So we've got sperm from two different sources. Firstly, we have locally recruited sperm. So as Hugo mentioned, we've done a big sperm donor drive earlier in the year. Our men have been having their medical consultations, doing all their testing and counselling, and the sperm's now in the process of being quarantined. The other sperm avenue that we have is imported sperm from the European Sperm Bank, and we're at the process now that our counselling team are starting to provide counselling to those donors. So even though we can get sperm from overseas, they still need to comply with all our laws and regulations, have the same tests done, do the counselling. If you are interested in donor sperm, you can send an email to hello@newlifeivf.com.au and just register your interest for donor sperm, and as soon as we have the sperm available, we can get in touch with you.
If I'm doing home insemination, can I see a fertility specialist to do all the checks prior? And the answer to that is yes. And in fact, not even a yes, but yeah, you probably should. So we've discussed along the way different reasons that people are infertile or find it hard to get pregnant. And part of that is knowing when to the correct time to have sex for couples. The same applies with donor sperm. So if your periods are slightly off, it's good to get checked up to work out, one, why are they off? Why are they not occurring regularly? Are you ovulating? We can give you information on the correct time to undertake donor insemination at home. On top of that, we can check both you and the sperm donor for any infections. We can do any of the genetic screening that we would do otherwise. You just then you have, you undertake the home insemination at home. So yes, a fertility specialist is always worth seeing, even if you're doing this at home. The other benefit of it is if it doesn't work, which as I said, it's only about 20%. If it doesn't work, then we've already undertaken all the blood tests, all the genetic screen, all the other investigations that are required for you to enter into a more formal treatment. The last one, if you're trying to be a bit sneaky, if you know that we've described, you know that there's a 3-month wait before you can use donor sperm because of the quarantining process. So maybe something you want to do is get the chap to come in, give a sample so that we can test it, just to make sure that there's nothing wrong or that he doesn't have low numbers. We can freeze that sample and then you can go about and do your own home insemination. But by having that sample, you've already started the 3-month process of waiting. And so if it doesn't work, you've already got a sperm sample ready to go with your first insemination. So short answer is yes, you can and you should see a fertility specialist even before starting that. Nicole?
So the next question that we had was, can I provide my eggs and can my partner carry the pregnancy? And that's what we call egg sharing. So you can definitely do that. The second part of the question is, how do we know which person should provide the eggs? So as I mentioned before, sometimes within a couple, there's a preference. Sometimes if you are both wanting to have your own biological child, so from your own egg, sometimes I would suggest, well, maybe you could start with the older partner first, retrieving their eggs, because obviously women's egg quality deteriorates as they get older. So the best chance with any woman's eggs is going to be now when she's at her youngest. But sometimes if one partner is already quite old, maybe her chances will already be quite low, and so a couple might decide not to use her eggs and just to use the younger partner's eggs from the beginning. Another option is having some baseline tests like an ultrasound or an AMH test to see who has more eggs, because ultimately if one partner has only a few eggs, you may get more embryos and better results if the other partner has more eggs. So they're things to discuss with your fertility specialist, and they'll take you through all the tests and go through the results.
Do I have to try insemination first, or can I choose to do IVF straight off, even if the sperm is okay? And the answer is, yeah, the choice is yours. It's really up to you which way you want to go. Well, it's between you and your fertility specialist. If you're being counselled properly, you'd be told the success rates of each. So we tended to go with insemination, IUI, usually with the medicine to help you ovulate, because it's effective. And if you remember when I spoke earlier, I said that women in this situation are not infertile. They just don't have everything coming together at the right time. So by doing IUI and maybe using some medicine to help you ovulate, we're just making everything come together at the right time. It is effective, and it's a good way to, I suppose, do it on the cheap. The issue is that the success rate is not as good, and it's really not that cheap. There's quite a bit of science involved still in spinning down the sperm, in concentrating it, in preparing it, and then in the background of trying to make you ovulate. So some people move directly to IVF. Now, IVF will give you higher success rates, and depending on your age, those success rates can be quite dramatic between IVF and IUI. So it will give you higher success rates, but of course it's more expensive than doing IUI. But I often do this bang for buck situation with my patients, where I sort of describe both processes with them. And really, bang for buck, depending on age, IVF is going to be better, because in IVF we can normally get a good number of eggs. We can create a good number of embryos, and putting back an embryo as compared to putting back sperm will give you a higher pregnancy rate. And if you divide the overall cost per embryo, it usually works out cheaper to go straight to IVF. Now, that doesn't apply to everyone, but it does apply to most patients. So no, you don't have to do IUI or sort of the earlier treatments. You can go straight to IVF, and that's just a discussion between you and your fertility doctor.
So the next question we had is whether the donors are screened for every possible genetic condition. And the answer to that is no, they're not. There are over 25,000 different genes in the human genome, and we are not at a stage yet where we can screen everybody for every single genetic disease. So what we screen for are some of the most common serious genetic conditions. So they include thalassemia, cystic fibrosis, Fragile X, and spinal muscular atrophy. We also do what's called a karyotype test on the donors, which is checking their chromosome pattern as well. So if we find that the men are carriers for one of these things, then if someone is going to use that particular sperm donor, then they would obviously be alerted, and we would organise appropriate testing for them to make sure we minimise the chance of having an affected child. When you do IVF, you can do pre-implantation genetic testing, and that can look for genetic problems and also chromosome problems as well. So as women get older, their egg quality unfortunately deteriorates, and there is an increased incidence of chromosome problems in pregnancies. And that's something different to the genetic testing that we do on the sperm, but we can do that additional testing, and that's looking for things like Down syndrome. So that kind of thing we do on the embryo, and the things like cystic fibrosis and thalassemia we're doing on the sperm donors.
So we've got here how many families can sperm donors donate to, and then it says in Queensland, and the rest of the question is missing. So look, the answer is that like many things, as we've discovered with COVID-19, many things is different between the different states around Australia because of obviously each state can run its own affairs, and this is particularly so in rules regarding fertility. So in Victoria, we have quite stringent laws, and the law essentially says that a guy can father or can create 10 families, including his own. So that means if we reserve a family for himself, whether or not he plans on having children in his own family, children in the future, you can really only create 9 families. But within a family, there's no sort of limit on how many children. So you can have 1 child, you can have 10 children within a family. So 9 families. The issue really is when you have a donor is whether or not there's any sperm left over. So a guy can donate a certain number of straws, and we'll have that in our stores. But if that gets used because multiple people have used the sample and we run out, it means that that sample is not necessarily available to have any further children. So you may have 1 child by 1 donor. The hope, and what we always try to do, is to offer you the same donor so that all children are born to the same father. That's not always possible. So even though they can create 9 families, they won't necessarily reach that limit. And even within families, they can create multiple children. we hope to be able to allow that.
So the question I had was, is it better to have a younger sperm donor? And the answer is yes. It's not to the same degree as women. So as men and women get older, our egg and sperm quality deteriorate. It's definitely more deterioration for women than for men, but definitely we do know that the sperm will tend to be better quality if it comes from a younger donor. We actually put a cap on our age for sperm donors, so we do say that they shouldn't be over 45 years old. That's for our clinic recruited donors. We know that as men get older, there's an increased incidence of things like autism spectrum disorder in offspring. Sometimes though, people do come with older donors who they want to use because there's a genetic link. So someone might want to use their father who's older but is otherwise healthy. So yes, the younger the better, but at the same time, if you have a donor you want to use, we'll just do our normal screening tests and still happy to use them. The next question is, how many IUIs are required before a successful pregnancy? So as Hugo was saying before, the pregnancy rate's about 10 to 15% per IUI. So, you know, some people will get pregnant first go, but there will be some people who take several goes to get pregnant. And so sometimes it comes down to how long you want to keep going. Often we say, try 3 times, and if you're not pregnant, that might be a time to move on to IVF. But if you feel comfortable and you want to try more times, sometimes you can. And also if you try once and it's not successful and you're feeling it's the right thing for you to move on to IVF at that point, then that's okay as well. So there's not a set limit. We would say try 3 times, but it's not a great pregnancy rate at 10 to 15%. Even after 3 goes, you know, probably only a quarter or a third of people will be pregnant.
Question, can I donate eggs to the clinic? Please do. At a recent, one of our recent drives for sperm, we actually had a couple come to see us, and they actually themselves didn't want to become parents, but he wanted to be a sperm donor, and his wife sort of out of nowhere sort of went, well, actually, I want to be an egg donor as well. And I actually saw both of them to sort of work them up and do that testing that I discussed earlier. Sperm is a relatively easy process to go through in the donation process. It's a little bit more for women, and there seems to be a bit more of an emotional attachment, I suppose, to women and their eggs. But it's an amazing thing to do, to be able to give someone a child. You know, if you think you're thanked and worshipped and loved for being a sperm donor, imagine that 10 times more for being an egg donor. It really is an amazing gift. And if you are interested in doing it, you just need to call Newlife IVF, and you can always get us at hello@newlife.com.au, and our people will discuss it with you. But yes, please feel free to donate your eggs. On that, we also do embryo donation. So there are some patients who finish having their families and maybe have embryos left over. They too can be donated, and they too are like gold to a person or a couple who are wanting to have a family. So yes, ask the question, and I'm sure it's a yes.
So I think we might have one last question, and that is, do we have services for trans people to freeze eggs or sperm before they commence their fertility treatment? So we don't have a specific trans clinic, but absolutely you can freeze your eggs and sperm before you begin your hormone treatment. So what I would suggest, if you get onto our Newlife website, you can have a look at our doctor profiles, see who you like or who's closest to you to get to from work or home, make an appointment, and we can very easily organise for you to freeze sperm or to go through an IVF cycle and freeze eggs if that's the case. So definitely there are services that we offer for sure. So I think we're at the end of our presentation and the end of our questions. So I hope you found tonight informative, and we'll see you next week. I think it's Hugo and I again. So you've got the A team 2 weeks in a row. Okay, see you.